Thank you. Thank you for the invitation. So I think it's an interesting session, and I think it's going to be a complementary view approach to cancer pain. And yeah, I'm glad there's a whole session on cancer pain. So maybe we've been talking the whole morning about cancer pain, and maybe first of all, why do we need to do that? I'm not sure if we have anesthesiologists or pain physicians in the audience, but there are so many medications and people try so much. But why actually do we need to still use surgery? And the answer is unfortunately that medications are not enough. So if we look at the whole cancer patient population, most of them will suffer from pain at some point during the course of the disease, about 80% of them. And unfortunately, despite all the available treatments, about 50% of cancer pain is undertreated for various reasons. And even more disturbingly, or the patients that we want to approach are 10% of patients who suffer from what is called refractory or intractable pain. That means pain that is intractable. We saw in the morning the WHO ladder, so not just any pain that has tried and exhausted all the possible treatments, and they're still suffering from severe pain, like patients you see in these pictures. So Girish also already showed something similar to this. Usually our instinct when we see those patients, so this is like a typical patient, right? This is how they look when you see them in the oncology ward. They call you for a consult, and you see this patient, they're about to die, and your first instinct is to say, no, we cannot do anything, right? If you call an anesthetist to evaluate them pre-operatively, they say, no way, we're not doing any anesthesia. They will not be extubated at the end. So if you even want to consider something invasive in those patients, it has to be, like Girish said in the morning, it has to fulfill certain criteria. It has to be quick. Those patients cannot lie down for a very long time. It has to be minimally invasive, so no big incisions, no CSF leaks, no wound issues. Without general anesthesia, and it should produce immediate pain relief. So the patient goes into the operating room with pain and comes out without pain, and the next morning they can be discharged or sent back to the oncology ward for further treatment. You do not want to get stuck in your department with those patients with complications. Right? The idea is not to get them complicated, but so they can move on. So what can we do? So as neurosurgeons, we are privileged. We can intervene anywhere along the pain pathways, and that's been described in the morning, so I'm not going to repeat that, but we can intervene practically anywhere along the pain pathway. We don't have to stop at the door. But what should we do, right? So a lot of treatment have been described today, right? So we can basically divide our treatment into two main categories, right? There's the there's the old neuroablation, the RF techniques, and that's been used for many decades now. And in the past 2 decades, the pendulum has shifted towards neuromodulation, and we've heard about motor cortex stimulation, spinal cord stimulation, intrathecal pumps, and so on. And those are techniques are very, very useful, and they are reversible. So they're neuromodulation and don't cause any permanent damage, but they require a relatively bigger surgery, so you need to do a big incision. They're very labor intensive. You have to program the stimulator, you have to refill the pumps. It's more of a surgery, and I want to argue that for cancer patients, specific for terminally ill cancer patients, neuroablation with radiofrequency, a small minimally invasive technique, is preferable. So we've heard, so we can intervene anywhere along the pain pathway. So how do we choose where to intervene for a specific patient? And I find it useful when I see a patient in the clinic to broadly categorize them into two categories. Either they have focal regional pain somewhere along, at least unilateral pain on one side of the body, or they have diffuse pain. Girish thought it makes the distinction between bilateral pain and diffuse pain. Yeah, it's always a debate, like, well, what does the patient have? But broadly speaking, if the patient has focal pain or regional pain, I'll keep it simple, then the best way to help them is to disconnect the spinothalamic tract somewhere along the way, and that will it's a binary result, right? It's either on or off. It's 0 or 1. If you disconnect the pain pathway, it's like cutting the cable from the electricity cable from the switch to the light bulb, right? If you cut it, then the light is off. The brain doesn't receive the signal. So then it depends on the distribution of pain. If the pain is low, below the cervical level, you can do a percutaneous cordotomy. If the pain involves the head and neck, then doing a percutaneous cordotomy at C1, C2 will obviously not help that pain, and then you have to go a little bit higher, and I'll describe that. And for visceral pain, there's a specific pain pathway that I'm not going to go into. It's a visceral pain pathway in the dorsal columns. You can do a medial myelectomy. For diffuse pain, and I completely agree, for patients who have this bony metastasis with diffuse, ill-defined pain, usually I would go for a singulotomy, and I'll give a few examples. So, all right, what would you do? What would you offer this patient? This is a 42-year-old man with a metastatic sarcoma, right? He's lying now on his right side. This is his left hip. He underwent multiple lines of chemotherapy, had orthopedic intervention, got complicated with necrosis, infection, and so on. And now he's left with this open necrotic wound. I think it's obvious to anyone in the room, right? No matter how many opioids you give him, it's not going to help. He needs something different, extreme. Oh, this lady with a metastatic melanoma invading the chest wall. And I could keep on and on going. There are many examples, unfortunately. So if we look at those two examples, they both have pain and below C5. So they have pain below the shoulder level. So according to this flow chart, the best treatment for them would be to do a cordotomy. And cordotomy has been described already this morning, but you know, when I first started doing cordotomy, when I first proposed it to my oncology colleagues, they said cordotomy, it's like, it sounds scary, right? They're crazy, what are you going to cut the spinal cord? So it's actually, maybe it's better called selective cordotomy, right? So it's a tractotomy. We are disconnecting the spinothalamic tract. And so it's been said it's best for patients with unilateral pain, and you can do it either open or percutaneously. And if you want, so it was asked before, why do we go between C1 and C2? So if you look at this diagram, right? So this is the anterior spinal artery. In blue it's the spinothalamic tract. This is the corticospinal tract and the dorsal column. So we want to approach somehow the sensory spinothalamic tract without injuring all those critical structures. So one way is like Dr. Girish said before, to do it in open way and to rotate the spinal cord, but that's a relatively big surgery. So you have to do a skin incision, laminectomy for patients who are malnourished, they have wound issues you want to avoid. So why do we go to the C1, C2 space that was answered? This is the answer. If you look at the lateral X-ray, you cannot go in between C3, C2, C3. So you just cannot come through, right? So the thoracic cord, you have to go through the thorax and the lungs. That's in the way. And below C2, the cervical vertebrae are like roof tiles, one on top of the other. And the only place you can place a needle safely is between C1 and C2, between the atlas and the axis. So because this allows us, half of our rotation, so there's enough space there between a half a centimeter and a centimeter, and this is our surgical tool. So a spinal needle, a 20 gauge spinal needle, and we insert this electrode through it. So this is how it looks. So there are two techniques to do it, and that's why I said it's complementary. The two talks. One way is to do it with the C-arm, which I think is technically more demanding. So it's much more difficult to see the spinal cord. The other one is using a CT or an O-arm. I use the O-arm because I have access to it in the operating room. CT, I don't get access to the radiology department. So this is where the needle ends here, and this is just the electrode continuing on, and this is the exposed tip. So the diameter is 0.3 millimeter, so 300 microns, and the exposed tip is 2 millimeter long. And what you see here, right? So this is the C1 level. You see the dents, and this is the spinal canal. We injected contrast, so the CSF is white, the spinal cord is here. It's this dark structure. You see the needle ending here, and this is the electrode coming to the anterior, the ventrolateral part of the spinal cord. And once we are there, we use mapping, like was described, both motor and sensory. So this is how I set up the room, right? So the patient is lying supine. I don't use. I saw you said you're using a 3-pin hand holder. I was using it in the beginning, and I found you can just tape. So I tape the head to the bed so the patient doesn't move, and he's awake here, right? So. Okay. No. So you see he has a nasal canal, so he's awake, and like Dr. Gigi said, the approach is 1 centimeter below the mastoid process. And this is, I hope the video runs. So this is how it looks, right? So you do, it's just doing a cervical puncture. It's like doing an LP, but in the cervical spinal cord. So you go in, and I fluoro on the way, right? So it's not shown here, but I go in and I make sure on the fluoro that I'm approaching the right height. Obviously, once we are there, you just see CSF coming out like here. And then once we are there, this is what you see without contrast. So you can't really see anything with the O-arm. It's not a CT. With the O-arm, you cannot see anything. So you have to use a contrast. So you can either inject the contrast when the needle is inside, and then you get this nice demarcation of the spinal cord. What I do now, I actually inject the contrast before we start. So I do a lumbar puncture. We inject 10 cc's of water-soluble contrast. I put the patient with the head down for 20 minutes, half an hour, let the contrast mix, and then you can use it from the beginning. And again, this was already described, but I just showed the video. The resolution on the screen is better, but we look here at the impedance. So the impedance in the beginning, maybe on the screen you can see it better. It's about 100 or 200 ohms in CSF, and once you touch the spinal cord, it goes to 400-500. When you're inside, it's usually 600-700 ohms, so above 500. It should be when you're inside the spinal cord itself, and then we use the. So this is what we want to see, and then we use the mapping, and I show a short video that was already described, sensory and motor testing. We do, so it takes time to build the practice. In the beginning, I did the first patient, then the second one was 6 months later, and then 3 months later, and so on. Now I guess we do about 2 a month, so we've done more than 120 by now. This is from a few months ago, so 120 procedures, about equally between men and women. And this is how we do again, just to illustrate what we do with the mapping. So what you see here, right? So this is I combined my 3 talks together, so we have 45 minutes. Okay. So if we look here at the spinal cord, this is the midline of the spinal cord. This is the ventrolateral. If we go down to the diagram, then this is the dentate ligament. We want to be anterior ventral to the dentate ligament, and the electrode goes into the spinothalamic tract. And what we do when we stimulate, we want to make sure, just for the illustration purposes, that we activate this part of the spinothalamic tract, and we want to get the sensory, the sensation at the very low threshold, so below 0.2 volts. And then we want to make sure that we are far enough, so we don't want to cause any damage to the motor tract. The motor, this is the corticospinal tract here. So we stimulate at a low frequency, and we want to make sure that we are far enough. Obviously, if we use a very high intensity, we'll activate it at some point. So I use a 0.6 volt as a threshold, which is, I think, pushing it to the lower limit. I started with 1 volt, then 0.8, and now I dare go even as low as 0.6. So this is how it looks. The patient is lying supine. Dr. Zegerman, that's my regular anesthetist. He's slowly, and again, the resolution is good, but I think on the screen you can see it slowly goes up with the amplitude of the stimulation until the patient, there's no volume, but at some point he'll say, when he feels it in his leg. So he has pain in his right leg, and at some point he'll jump up because he went up too quickly. He feels the pain, and then we slowly go up and we find the threshold. Once we are there, we know that we have the right position. We want to make sure that we are not causing any damage, so we use the 2 hertz stimulation, and you see here that we went up to 0.9. There was nothing. Only at 1 volt he started getting the motor control, which means that we are far enough. We are at the safe distance from the corticospinal tract, and we can do this. And you can see here on the sign in this illustration at one point. So here in this case we were too close. We were in the middle of the spinal cord, and we got the motor contractions already at 0.5 at 0.5. I think here it's 0.5 volts. So this is too low, it's too close. When we readjusted and moved the needle more anteriorly, now the stimulation, now the activation is only at 1 volt. So 1 volt is safe enough, and you can do the ablation. And this is how an MRI, a post-operative MRI, looks 1 day after the procedure. You see the T2 changes here that are localized to the ventrolateral part of the spinal cord with a little bit of edema going to the side. Just again, it doesn't, so when you start you have to be prepared. It does not always doesn't always go to the right place in the right and on the first try. So in this case, this was the first attempt. You see the needle is here in the posterior and the dorsal columns. So when we stimulated, we activated the dorsal columns, we got ipsilateral sensation. Then we to move the needle, and in this case, now it's in the middle of the cord. Now we got contralateral sensation because of the corticospinal tract, but a low threshold motor activation. And only when we were here, this was the final position. And another point to notice, and I think this is maybe one of the reasons it's easier with a CT or an arm, is that the spinal cord moves all the time. So if you look here, right, so here it was pushed ventrally, now it's pushed to the side, and you see, so the position changes. You cannot get that with the C-arm, so you have to know and be prepared with the C-arm. It's more challenging. Again, another example, the spinal cord is pushed to the back part of the spinal canal, so you cannot really see that without contrast. Again, a few examples of how an MRI looks. In this case, I think we did a too big ablation, and it crossed to the other side, so like limit the ablation size. One of the works we published, we showed that you don't need to have a big ablation. So even if the ablation is 10% of the spinal cord, if you're exact in the correct position, then it's enough to take the pain away. One important point is regarding risks. So when you go between C1 and C2, you usually the vertebral artery goes above C1, but I think there are like 1 or 2% of the population have like an aberrant vertebral artery that loops down below C1. So at some point, I don't know, I read this article, and we started doing routine CT angiography, and I had 2 cases. This is from the literature, but this is one of my patients that we saw this loop, and we abort. So I do that the day before the procedure, and we canceled the case. So yeah, try to get a CT angio before the procedure. Those are our results. So again, in over 100 patients, usually you get a very good immediate pain relief in about 95% of the cases. And this is one of the cases. This is the oldest patient we've treated, an 88-year-old woman. This is one day after the procedure. So it's a minimally invasive, usually well-tolerated procedure. She was bedridden for 3 weeks before the procedure. And this is, again, another patient with a family. So we give them, the satisfaction of spending the last few weeks of life without pain. And that was also asked before, so what is the duration of pain? Because we know we do the ablation and the pain might come back. So what we see in the Kaplan-Meier, on the left side, that's the survival, right? So most patients die within 3-4 months. And this is the failure of the pain. So in most patients, all those lines are the ones that were censored. So in most cases, the pain doesn't have time to come back. So most patients die before the pain returns. We don't have a long follow-up. The median survival in our series was 3 months. So we get the referrals very late. Complications. So when you do more procedures, you'll encounter also some complications. About 20% complication rate. Most of them are mild and transient and go away, and some headaches and some maybe ataxia and so on. We had 3 patients that had severe complications, so about 2.5 or 3% of patients had hemiparesis, one even with hemiplegia. And maybe the most, so this was the case of the hemiplegia, and this is why I started injecting the contrast before I do the procedure. So this was the initial approach. The needle was here. The patient was very painful, had a very hard time lying right. So this was the initial approach. I injected some contrast. We did not see well enough, so I decided to inject some more. And during the injection, it jumped, and this is what happened. So you see the contrast here, it's intramedular. It went into the spinal cord itself. And this is how it looked on a post-op CT, right? You see the contrast inside the spinal cord. He was left with hemiplegia and also severe myopia on the other side. So very unfortunate case. Luckily, it was case number 10. So by then, like the oncologist already trusted me, and they kept on referring patients. So as long as you keep your complications rate low and have a good communication, it will work. So at least in my experience, so most patients don't report the mirror pain. When you ask them specifically, when you ask for that, you find the mirror pain. This is the most troubling side effect, mirror pain, in about 1/3 of patients. In most of them, it's mild, and they don't even report if you don't ask them. And 5% or so, 5 to 10%, they have severe mirror pain. Small aminotomy and just crush or cut the both bilateral, both parts of on the 2 sides of the midline raphe. You just crush it with the forceps, and it helps. Again, it's a bit of a bigger surgery under GA, so that's why I don't know, we don't use it, and I prefer cingulotomy, but that's a viable option for cancer pain. And also today, I think our pain clinic is doing much more celiac blocks and other blocks that now I get the patients very late, and then it's too late to do that. Yeah.
So in cordotomy, do you take real-time feedback from the patient to confirm the need?
Yeah. So after we've done this, I usually use like a pinprick just to make sure that the area around that region is numb to pain cessation.
In your practice, you already know how many of the cordotomies you have done, but for the mesenchymal tractomies as well as the cingulotomies, how many of the numbers are there?
So I think mesencephalotomies we've done 5, and the reason for that is the referral patterns from the oncologist, from the pain clinic, from the palliative care. It's I think mesencephalotomy is a great procedure for the oncologist. For the palliative care, it's easier to refer for percutaneous cervical procedure, which is perceived as less invasive, less dangerous. Although I think doing a cordotomy C1, C2, it's not less dangerous than doing because I do many more DBS. So the approach is, but it's a psychological issue with the referring doctors. And not my preference. I don't get so many head and neck referrals. I'm working on it.
And one more on the slide, cingulotomy you showed that over time there is improvement. So at 1 year it is better than 6 months.
Now, so that I showed something from the literature. It's not better at 6 months. You have to look at the end. So the number declines. So from the patients who survived, there were a bit more there, but patients are lost to follow up. And in my personal series, so the median survival was 4 months. So I don't have a 1 year follow up on cingulotomies. We've done, I think, more than 30 cases. but most of them die within less than 6 months, usually 3 months or so.
I feel that because we do a lot of gamma knife, I think we can do radiosurgical cingulotomy as well as mesenchymal.
Yes, you probably could. You could. The question is the time to the effect. So with cingulotomy, with RF cingulotomy, the advantages, at the end I do a very small incision and I do small bone. The effect is immediate. With gamma knife, I guess the effect would be, after a few weeks, a month, and by that time the patient could be dead. For mesencephalotomies, there is a series now by you'd have to give a very high dose of energy to a very small target in the brainstem, and you don't have any real-time feedback for gamma knife. So you might end up with radiation necrosis in the mesencephalon without. So I would be a bit hesitant about using gamma knife for mesencephalotomy. There's a trial now going on by Jeff Elias in Virginia for doing HIFU, for doing FUS mesencephalotomies. I think they have some promising results. Yeah.
But in those terminal patients we are talking, so we're not bothered about the radiation necrosis down the line.
Yes.
And it doesn't require sedation and anything like that. That's one of the bigger advantages in our center, because anesthetist time is also valuable. We don't get that time until.
Yeah, it's a question. I don't know. I've not done it, but then, like you say, they might not develop radiation necrosis, but maybe the effect will be too late for them. So
that's one thing we need to find out.
So just one more thing. In cordotomy patients, do they have issues with temperature, sensing cold?
Yes. That's one of them. Sometimes you get a call. We always tell them, be prepared, but you have to hold a cup of tea or coffee in the other hand, don't you? Because you will get Batman. Sometimes I get calls, like after a day, they get home, they take a shower and they call us. I don't feel, the hot water on one side of the body. Yes, that's the sign that it works. That's what we wanted to do. But you have to prepare patients for that. Yes, definitely. It's pain and temperature together. It's a side effect, but it's something what we want. Yes.
When you place pumps in your treatment?
I don't. So I've done a few. We don't have the support team to take care of the intrathecal pumps. So I've done 2 intrathecal pumps. So we do them for spasticity, and I have a team to treat, to do the baclofen refills, and we do pumps for spasticity. For pain, I think I've done 2 pumps for that. And then the question is, who takes care on and the pain clinic? So I decided I'm not doing that. But theoretically, for patients with more than 6 months to live, with like 1 year or more of prognosis, I think intrathecal pumps are great. You just need to have it's a financial issue. So you need staff. Yeah.
So I do one very fundamental question that so once the pain is fine, the patient is very happy on the day 1. Then after a few days, they forget about the pain because it is not that bothering now. And then the trade-offs of that numbness and lack of temperature sensation that comes in, right?
Yeah.
So do you feel in your practice that they start becoming unhappy about that anesthesia? Is it the case, or are they still happy in general?
They're happy in general. For the pain, you have to be realistic in your expectations. Those patients are in a bad condition. Most of them are so late. They don't, that it's almost too late for them to take advantage of the improvement in pain. They are still weak. They're sick. So they go, they go home. They suffer less. They're happy. The family tells us they're happy. But it's like we try to get the referrals a bit earlier. What we do see, we saw a few times, is sometimes that the pain is away, and suddenly the patient get depressed, because until then they were so bothered with the pain, they were not really coping with the disease and really realizing they're going to die. And suddenly, when the pain is gone, they come back for after a few days or a week for follow-up. And they are depressed, and now the truth is something that they are going to die within a couple of months. My palliative people tell me that's good, because now they can start to do the real work with them and prepare them and the family. to say goodbye. So the palliative care. So that's why you have to do that in a multidisciplinary setting. You have to have someone who is ready to take care of the patient and do the work after the pain is gone.
Right. And for a patient with a unilateral pain who will be eligible for cordotomy, but having life expectancy of say 2 to 3 years, then would you prefer cingulotomy over?
No, I would not offer them any
of these?
destructive procedure. I would go for pump or for a stimulator.
Okay.
Spinal cord stimulator or an intrathecal pump. I'm just referring to a different center. So there's another hospital that does pumps.
Right. So do you have any experience in cingulotomies in such
No.
pains? No. Okay.
No. One. I've done one case of a patient with CRPS, and it's a different story. And the pain was gone. It was great. He was drinking Oxycod out of like 4 or 5 bottles of Oxycod a day. Like he was just going and drinking out of the bottle Oxycod. Again, the immediate effect was great. We was able to win him that's also very interesting. There's no withdrawal as side effects when you cut down. It's very fast, but after 4 or 5 months, the pain was back to baseline. It was back. So I don't do that for chronic pain. I do that only for cancer pain.
Thank you.
Thank you.
I think we have
Thank
to
you.
go on with your time, right? With the next lecture.
Yeah. Thank you, Professor Strauss. Yeah.